Hello and welcome to today's Map Chats webinar, Treating the Whole Community, Addressing Social Drivers of Health. I'm Bernie Langer and I'm a Senior Data Analyst at PolicyMap. PolicyMap, the organization behind this webinar series, is a national online mapping service that provides maps and data visualization tools for tens of thousands of indicators related to housing, health, demographics, and more. We'll talk a little bit about PolicyMap at the end of the webinar. Map Chats is a free webinar series that we offer that features experts from a variety of topics, including housing policy, community and economic development, healthy food access, placemaking, and other areas. Our speakers discuss how their work incorporates data and mapping. We'd love to hear your questions throughout this webinar. Just use the question panel on the GoToWebinar interface, and we'll answer as many as we can after the presentations. Also, the webinar will be recorded. You'll receive an email with video and the slides after the webinar if you want to look at them later. They'll also be posted at policymap.com. If you want to start a conversation during the webinar, if you're tweeting, you can use the hashtag MapChats to join the conversation on Twitter. So today we'll be hearing from two really interesting figures in the field of public health, Sarah Dixon from the Iowa Primary Care Association and Amy Carroll-Scott from Drexel University's Dornsife School of Public Health. They'll be talking about knowing and understanding social determinants of health, how social determinants of health can be used to improve health outcomes for patients and communities. The first presenter is Sarah Dixon, the Senior Director for Emerging Programs at the Iowa Primary Care Association. She responds to members' needs in the areas of healthcare delivery system reforms and clinical quality performance improvement and transformation work. She provides leadership to the interdisciplinary transformation collaborative team and operations of Iowa Health Plus, a clinically integrated network of community health centers in Iowa. Additionally, she leads development work on emerging programs focused on vulnerable populations, innovative partnerships, and programming related to social determinants of health, and assisting the health centers in Iowa to better connect to the needs of communities they serve. I'll turn it over to Sarah.
Well, good afternoon, everybody, or good morning in the case of the Pacific time zone. I'm really happy to be with you here today, and thanks, Bernie, for the introduction. I will be talking about a tool called Prepare, and I am going to work to advance the slide here. So Prepare stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences, and it was a tool developed with a number of national partners that I will mention a couple of slides later, really designed to standardize the way in which we look at the needs of patients from a more non-clinical perspective within our electronic medical records. And so the idea is that we want to engage patients more holistically, think about how there's identified social determinants of health, whether they're assets for the patient or barriers for the patient might impact their overall health. And then we want to work to respond to those needs in a different way than maybe we typically have as healthcare providers. So just to be clear up front about the Prepare domains, I put together this slide to just show the audience what factors that we are looking at in the Prepare tool. Many of them are they're pieces of information that we would capture in our electronic medical records, typically our practice management or registration systems. And then there are places in the EMR where we might be doing a health history, but not necessarily designed to be action-oriented to impact the patient and think about their care in a different way. So the non-UDS is the term for the domains like 10 through 16. And those typically are built as content in the electronic medical record. They don't necessarily exist in the practice management side of the house if you're from a healthcare setting. And then when the group that built the tool, we did add what we consider core plus measures, and we built content to reflect all of the measures that are listed here, plus core granular. And I think the idea is that we want to be able to have a standard set of measures that we can roll up and look at aggregate levels, such as a statewide level, maybe a regional level or a national level, but also provide flexibility to healthcare organizations that might be using this tool to get more granular if there's some specific questions that they want to ask. But we'd like it to roll up into these broader questions so that data integrity is in place. So when we were really thinking about starting this process and implementing a tool within a couple of pilot health centers, there was work done with our other pilot sites across the country to really think about why are these questions important to ask, and how might we think about using this data in a number of different ways. And so I really like this graphic a lot that our national association developed to really describe what we can do at an individual level with patients or families or care team members that might engage and interact with those that they're serving in a different way. From an organizational level, we've seen health centers that have been capturing this data really think about not only the design of their care teams, but also the way in which they might proceed with adding new services in-house within their clinics, or the way in which that they interact with local partners to try to bring resources that already exist to benefit the patients. And then from a community local health system perspective, we've been able to, I think, really bring data forward that allows for initiatives such as CMS's state innovation model to think about how additional players such as public health organizations or community action organizations really do belong at the table when we're thinking about making delivery reform changes within our state. We've also come to the table with payers thinking about this data and suggesting that the risk stratification methodologies that have typically been in place from a payer perspective might not necessarily capture everything that's important to vulnerable populations that we're serving. And then you can obviously use this type of data at state or regional, national policy-making levels as well. And I think having healthcare providers come forward to talk about some of these social drivers of health, they can be very effective messengers from that perspective. So these are the partners that came together back in 2014 to really bring Prepare to fruition. There was funding provided by the top 3 organizations, Kaiser, Kresge, and then the Blue Foundation of California. And then the content drivers were the National Association of Community Health Centers. APCHO is the Alliance of Asian Pacific Community Health Organizations, and then the Oregon PCA and the Institute for Alternative Futures. And then we were in Iowa, one of the pilot sites that actually came to the table to help design the tool and then build the content in our electronic medical record and test it. So people often say, why did you come to the table back in 2014? What motivated the 2 clinics that were the pilots? What were you hoping to gain essentially from doing this work? And, front and center, I think, to the clinicians that really served as champions for the implementation was an ability to look at the care of their patients and providing better care to their patients, because I think a lot of times they had a sense that there were these unmet needs and felt very at a loss, I think, to really help patients address things that were keeping them from maybe improving their health. And so there were lots, I think there's been lots of studies that have looked at primary care providers being really kind of fearful to ask these types of questions because they feel like they are at a loss for addressing them. And so the whole point of Prepare was not to just capture the data for the sake of capturing data, but to help primary care providers partner and design interventions within their own clinics to address the needs that were identified. They also, the centers that piloted this work with us, they wanted to be able to use data more effectively to either establish or grow partnerships with community resources. And so we've had some really nice gains in the areas of transportation in the case of one of our health centers, where they were able to take data and actually make a route change that made healthcare services more accessible to patients in a particular community. And then they actually, on a monthly basis, invite a partner agency to come to their social determinant of health committee meeting, which has led to all kinds of just better understanding about the services available and maybe a greater and stronger connection between the work that everybody's trying to accomplish. From the PCA perspective, you know, we care deeply about the first two topics that I discussed in this slide, but we also wanted to really think about how aggregating this data could be effective for ensuring that our reimbursement for the health centers was adequate given the shift to risk and value-based contracting. And also, I think, as a way to better describe the complexity of the patient population in a different way, in a more data-driven way. And so this is from this to screen or not to screen. That is the question that came from one of our clinical lead, Dave Faldmo, who's a physician assistant at one of the health centers that piloted the tool. And I like his use of William Shakespeare's quote, or his take on that. And he, you know, one of the things that I think people really want to know about is why should I do this? Why should I add this to the long list of things that I'm already asking patients about? You know, we typically are really good at screening for depression using the PHQ tool or PHQ-2 or 9 tools. We've gotten better at screening for substance abuse issues. So, you know, why another screening? And I think, you know, when it comes down to it, we really do want to be able to demonstrate the complexity of the patients that were served. I think also identify some of the positive pieces in patients' lives that they identify through the screening that might help us to better serve that patient and maybe use the supports that have been identified to build upon to help the patient get to better health. We also want to be able to look at differences in health outcomes or behaviors, and I have a slide or two that will show that. Evaluating the need for community-based interventions, influencing policymakers, and then this idea of going upstream, which I really like this concept, and I've got a nice quote about that later on in the presentation. And then I just wanted to, I'm going to show you data, and so the next set of slides after this slide really are focused on the outcomes of a Tableau environment that we've been working on. And so for those of you that really get down and dirty with data, this is for you, the multi-tenant database, and then how we're building the system to really benefit not only the Iowa PCA, but then also these clinic views that can help drive change at the health centers. And so I see a question, what is a federally qualified health center? Yes, you got that. And so this is, I think, the exciting probably part for this audience. So this is data from one of our health centers, and they have assessed, they've used the Prepare tool to assess over 13,000 patients. And then what we can show here is the screening rates by provider. So you can actually have conversations with providers about why they are screening patients or why they aren't. It gives you a sense of when assessments are being completed over a period of time. So if you did an educational intervention, you could see that that was effective to really raise the screening rates in the beginning of 2018. And then on the lower right-hand corner, we just did counts of the number of social determinative health indicators that were identified through the screening. So you can start to see where patients fall out and on kind of a continuum. And then this slide, we are going to pull out and look at some data quickly on Gabriel Compton. He was able to have 725 of his patients screened, and then the data updates to show you where his risk score frequency shifted compared to the broader population on this slide here. So this is where we isolated his data. You can see where his team was most active in getting the screenings complete. And so you can have a conversation with them about what maybe precipitated the drop going into 2018, when overall the center was increasing their screening. And then, like I said, that risk score frequency distribution will change as you look at the different providers. And then on this slide, just again, a little bit of a deeper dive here, where we are looking specifically at patients with just one social determinant of health risk and how many unique patients that speaks to, and what percentage of the total panel of patients he's serving are impacted by that. And then this gets at and isolates for patients assessed to date, those that have those higher levels of risk factors identified through the tool. And you can again see the breakdown by provider, so you can start to get a sense of, who's the provider that might have the patients with the more risk factors, and do we need to address their care teams differently? For example, do they need a social worker that really participates with them more heavily? And then this slide gets at how we can start to convey visually different components of the assessment question. So you can see the age and gender of the patients assessed, really what it looks like from a visual perspective on the education level question, and you could do that with really any of the data points. And then this gets into some of the insecurities that patients might have, and what percentage of patients are saying clothing insecurity up on the upper right isn't a problem for me, but for 6% of the population in this particular health center, that is an issue. So it starts to get at where are your bigger issues for your patient populations. And we have seen pretty drastic differences between the centers and the needs of the patients in different communities. Okay, then we get into how you can visualize data from a mapping perspective. And this slide shows the birth country of patients that were screened by our sample health center up in Sioux City, Iowa. And then as we progress, you can start to look at patients' birth country being the United States, or North America, being at 60% of the patient population. And then you can look specifically at even other subsets of the world and look at what rates the patients being served, where they are from and at what rate. And so I'll show you Africa. You can see just under 5% of the patients served by the health center, their birth country was in Africa. And as you drill down into different countries, you could start to, I think as clinicians, really think about, are there special considerations I need to think about as I serve patients from birth countries that might face different diseases, different education or cultural differences that would affect how they use the healthcare system in the US, for example. And then here we show you guys the Southeast Asia. And then I will be very brief on these last couple of slides because I really want to allow a lot of time for questions. But we are starting to look at the impact of these social determinant of health drivers on diabetes and hypertension. And so this logic or this logistic model, really what it shows, the summary I think that's most important is down at the bottom. So as you have increasing number of positive screens on the Prepare tool, your probability of being a patient with diabetes not in control increases by 13%. And then you can look at the difference between patients that identified not having trouble affording medicine or care compared to those who do identify that, and the likelihood that they are also not in control for their diabetes management. And then same with stress. And so this analysis just helped us to look at which factors within the Prepare tool might make it more likely that you do not have control for your diabetes or your hypertension. And then this slide here really focuses in on an initiative that this particular health center is working on, where they are going to specifically work on food insecurity within their patients with diabetes who are not in control, and see if that does, if an intervention around food security does help to bring those patients into control now that they know how food insecurity might be affecting that population. And then lots of future opportunities. I'd say we're at the beginning stages of this work. So we talk about documentation of services that we're providing as a result of knowing this data, looking for and identifying the most common determinants and thinking about how to address those in the best way. We're starting to think about cross-tabbing the results of the Prepare survey with clinical indicators, such as I showed on the last two slides. And then we can start to think about how do you create a new way of delivering care. So by thinking about different ways to staff or develop your care teams. We see a lot of implications around the patient-centered medical home model and how this social determinant of health data can be used. And then of course, we'd like to get to a place where we can look at risk differently, like I mentioned earlier in the presentation. And I'll end at on this slide where this is an idea of becoming an extremist, where you are wondering why people are falling into this river and being swept toward a waterfall. And so the first person jumps in, tries to save the people who are about to drown. The second person builds a raft so that they can impact more people and bring them to safety. And then the third person says, why are people falling in the river in the first place? That's where I'm going to go to find out if I can do something different about this. And so this whole idea from Health Begins is that we all need to go upstream from the healthcare provider perspective to try to better address the needs of our patients. Thank you so much.
Thanks so much, Sarah. That was really interesting, and I really like the idea of an upstreamist. I'm gonna probably take that with me. So just to remind everyone that if you have any questions, feel free to type them into the GoToWebinar interface. And we're going to answer everything after the next presentation. We have some questions already, and we'll get to as many as we can after our next presentation, which will be by Dr. Amy Carroll-Scott, who is an assistant professor at the Department of Community Health and Prevention at Drexel University's Dornsife School of Public Health. She is the co-director of the Policy and Community Engagement Core at the Urban Health Collaborative. Her research focuses on understanding and addressing urban health inequities and underlying social inequities, such as we'll hear about today. Prior to Drexel, Dr. Carroll-Scott was Director of Research for the Community Alliance for Research and Engagement at the Yale School of Public Health, where her work centered on the impact of community organization and multi-sectoral community-based chronic disease prevention interventions and policies on the health status of New Haven residents. So take it away.
All right, do I have control here?
You should, yeah.
All right, thank you so much for that introduction, Bernie, and thank you so much for your presentation, Sarah. I think I'm going to attempt to go a little further upstream, I think, using that upstreamist view. Sarah described their incredible work putting the right data into the hands of providers so that they can address the social determinants of health in their patients. And what I'm going to talk about are some strategies and example from my own work for putting data in the right data in the hands of community leaders who can make the kind of change in their communities which can hopefully create healthier conditions and avoid folks being driven with acute health issues into the healthcare system. So I'm going to talk a bit about the problem before I talk about some ways to solve it. Of course, we all know that there are persistent health inequities in communities across the United States. We know that about 80% of those inequities are actually driven by underlying social inequities, and we've been having a difficult time solving this problem. And there's a lot of reasons for that difficulty, but what I want to talk about today is the fact that we have a lot of community leaders in these communities who have the context, have the history, have the networks, and have the skills to best understand and articulate their own community's needs and to advocate for the needed change to be able to make improvements in their communities. Now, who do I mean by community leaders? I mean community-based organizations, whether health-based or advocacy or other issue-based. I'm talking also about community clinics, federally qualified health centers, other community-based providers, or other health programs. I'm also talking about community civic leaders, those who are the go-to for residents in their communities, or the connectors who know how to push the levers and the buttons with policymakers and representatives in their communities. And so they have this context, they have this skill base, but they often don't have access to the funds or to the grants or to the programs to be able to bring into the community. Another problem, and one that I'll focus on today, is that they often don't have the data that they need for the kinds of planning and advocacy that they do. Those of us, working with data and know the utility of policy maps data, know that it's very difficult to get publicly available data at the level where variation occurs, at the, not at the zip code, not at the county, not at the state, but it often is happening on a neighborhood by neighborhood level. And in fact, often sometimes on a block by block level. That's also the level in which solutions occur. Those are the identities in which people get civically engaged and try to take action to make health improvements. We also find that there's very little cross-systems data. Data often sits in silos, and those data are very rarely integrated in a place-based way so that we can take a look at what's happening in neighborhood A, B, or C. What we might be able to do is look at the patient population in neighborhood A from one health system, but we may not be able to look at the patient populations who live in that same neighborhood coming from other health systems. So integrating health systems data is often difficult or challenging, although through health information exchanges, there are attempts to fix that. It's also hard to see what folks in that health system are also receiving food stamps or DHS involved or criminal justice involved, are the systems that produce data in our municipal locations are very difficult to see cross-system in a place-based way in the way that community advocates and leaders would like to see it. As Sarah said, the complexity of patients is difficult, and they're trying to be able to describe them. The complexity of neighborhood populations is often also not described when we're looking at one set of data and not all of the data that we know that exists and could apply to that neighborhood. And then another problem is that community leader experience with data is often a barrier to seeking and utilizing data and research in their planning, organizing, and advocacy. Many community leaders do have some data and research capacity, but many do not, and it may not be aligned with their organizational mission. And so there's an experiential or a capacity divide between the data that they need to be able to program plan, to organize neighborhood residents, to advocate for needed policy changes, and they may be lacking that experience. Now, there's a few types of solutions that have a long history in public health, and I'm sure many of you are aware of. One is to build community leader capacity. As I just mentioned, around accessing or collecting and or using health data to inform their community health improvements through training programs or leadership development programs and the like, but they're not quite as prevalent as you would hope. Another solution is to include community leaders in research from the very beginning, from the conceptualization of the research questions to the execution, meaning the data collection and interpretation and conclusion drawing, and then most importantly, disseminating it to make sure that the data and the research findings are providing benefit to the community. We typically look at this through the lens of community engaged research approaches or community-based participatory research approaches. And they're one way to solve the problems I just described. And then another way is to share data and research results in ways that can be used for multiple purposes, to make sure that there's a publicly facing version of studies or research that's conducted that would have relevance for community leaders and what they're trying to achieve. And so I'll talk a bit more about that. So how is data being used for action in community settings? Well, community leaders are very keen to be able to describe community demographics and social inequities. Census data is great for community demographics descriptions, but as communities are fast changing through gentrification or migration or immigration, that could be very challenging given capacity issues we discussed earlier. Also, social inequities data is very difficult to capture, particularly at the neighborhood level, and Policy Map and others are working hard to fix that. But it's tough to get access to data sources that actually can be provided estimates at the level in which neighborhood or community leaders are looking for it. They're also keen to document pressing community health needs or to document health inequities, how their neighborhood or community compares to others. Also to use data to raise awareness or to mobilize constituents and policymakers around these health issues in their communities. They also use data to identify program or service needs, to see which ones are most amenable to their community constituents and also to see which ones have been successful in other locations. They also use data to develop programs or services, new ones, or to improve or expand existing ones. They use it to write grants and seek funding, just like researchers do. They use it to identify any needed policy changes and again to raise awareness or mobilize constituents and policymakers around those. They use it to identify existing assets or resources to know what strengths they can build from when making improvements in the community. And they use it very importantly for evaluating programs, services, or policies. So what can community dissemination look like? Well, as an academic-based researcher, a lot of research is disseminated through peer-reviewed scientific journals, and those are not typically accessed by those who are actually creating the change in communities. What they like to see are briefer reports, with all the information they need to know about how data was collected and what it's representative of and, descriptions of it, but in a briefer format that could be disseminated, that could be used in their own communication strategies. Online data dashboards, which shows them the data right there already analyzed for them. Infographics, which are a much more graphical way for conceptualizing data or results. They like to, community dissemination can look like press conferences or local media coverage or presentations to community residents and leaders. And I say, and discussion with in italics here, because it's not just presenting it to them and leaving, it's about presenting it to them and discussing what this means and how they interpret results. Also presentations to elected officials, again, to raise awareness about what was discovered. And also creating a process for sharing data or for community leaders to request summary reports from data that's collected from among their constituents as part of a co-ownership of data. Community dissemination should be more tailored to community geography, population characteristics, or health topics. They should be in more plain language, which means often avoiding or defining the kinds of jargon we typically use in public health or data and research reports. They prefer user-friendly graphics to lots of words, and clear titles, legends, or colors for those graphics that are easy to understand and see, as well as contact information for questions or more detail. There are lots of data folks in the community, and so there will always be folks who want to see the full report or the published material. So I'm going to give an example of a project I worked on, creating a profile of violence needs and assets to inform solutions in Eastern North Philadelphia. And the original study aims were to seek, integrate, and analyze data that was relevant to violence inequities in this area of North Philadelphia, which experiences everyone knows it experiences very stark inequities and violence, but had not been well documented in a way that community leaders could use. I also wanted to seek and create an inventory and map of community-based assets that could be leveraged or mobilized to address community violence, and then to create a profile that could be shared broadly with community partners and violence stakeholders citywide in Philadelphia. This was funded by the Drexel Urban Health Collaborative, and I just want to say that it's very mission aligned. As at the Urban Health Collaborative, our mission is about increasing scientific understanding and public awareness of urban health, and really putting data in the hands of those who are going to make community and policy change. So we conducted first a series of community stakeholder meetings. You can see here all of the types of stakeholders who participated, and the first set of meetings was just about what data do you need to do your work better, and how can we put it in, what kind of format can we put that in your hands. We also built consensus on what was the boundaries that would be mapped and where data would be integrated for this project. And what we heard loud and clear there was, don't provide us with a PDF. As soon as you provide us with a PDF of assets, it's going to be out of date. We have lots of resource inventories and directories that are out of date. So they asked us for a website. So we quickly changed our plan and we created a website. And our second set of meetings were a soft launch of the website, where we got lots of really great feedback about, data visualization, what was understandable to them in terms of colors and legends and the like, clarity, and also some ideas on dissemination. And then we, from that meeting, decided that a community launch event, we were told that a community launch event would be a great way to raise awareness about the website. We gave a tour, and then we had a series of discussions about next steps about fundings and programs and coalition building. So if you go to www.nuavnow.org or Neighborhoods United Against Violence, you will see our front page here. So I'm going to show you a bunch of screenshots here. As part of our asset inventory, this slide is just to show you that we were very rigorous and using snowball sampling and scripted interviews to identify over 40 violence and crime prevention or recovery programs in the community. And we really tried to dig deep into not just primary violence prevention programs, so really upstream youth development, workforce development, economic empowerment, but also secondary and tertiary violence prevention for domestic violence or crime victim services or anti-violence partnerships. And so what we created, which you can see on our assets page if you visit our website, is an interactive map that actually mapped all of these services. And if you've, when you're on the website, when you hover over one of these, it'll give you information about it. We also created an interactive assets categorical listing so that folks could just find out more by category, and you can see all the categories of assets that we inventoried here. And when you click on any one of those, it'll give you more information. For example, this is just a screenshot of the first 4 resources that you would find when you clicked on the behavioral health services category. Just to give you a sense of our data integration methods, we sought data, of course, to describe violence inequities, but also to describe the social determinants of health, neighborhood characteristics, and we based that on the Prevention Institute's model for community level trauma, which you can see below. And so we categorized those social determinants of health by people, place, and opportunity. And we integrated our data at the census tract level and mapped them using GIS methods. So again, if you go to our data page, you'll find parts of our site are about framing the problem of violence in Philadelphia, and in particular in this neighborhood. You'll also find our maps where we zoom in on the exact boundaries of Eastern North Philadelphia, which we came up with in that first series of stakeholder meetings, and then zoom in so that folks can really see neighborhood boundaries and census tracts. And you'll see how we describe what the maps are telling us. So this is violent crime incidents, and these are nonviolent crime incidents of particular interest to community stakeholders as well. Again, on the data page, you find people, And you'll find descriptions of this is the part of Philadelphia where the largest majority of Latino population lives. And also in this, we're able to show some of the demographic shifts that are happening due to gentrification. We also tried to show some asset base, like bilingualism being a positive aspect of demographics for workforce development. Under place, we have maps of vacant lots and buildings. We have maps of parks and recreation. And under opportunity, we have maps of labor force participation rates. And we have maps of educational achievements. And lastly, we have maps of out-of-school time programs. We also wanted to be sure, and this was due to our community stakeholders' requests, that we provided them not just with a PDF, but this was a brief that summarized all that's in the website in 4 pages that folks could use to raise awareness. But most importantly, we provided a page of the website where they could download all of the graphics that are peppered throughout the site to be able to drop into their own grant proposals, into their own newsletters or their own advocacy materials. And then lastly, in the meeting that we had, the launch of the website, we spent a lot of time talking about sustainability. We created a manual for website maintenance and have been working with a local CBO and have trained them to update the website. They've committed to do so under one of their violence prevention programs. We also talked a lot about ideas for grants and coalition building, including capacity building around use of this website and data in general, which we are currently pursuing. So thank you for your time. I look forward to your questions. And I also just wanted to acknowledge our project team from Drexel School of Public Health and from Congreso de Latinos Unidos.
Thanks so much, Amy. That was, again, a really interesting presentation. I definitely took a lot from it. We have a lot of questions being asked. I was going to start by seeing whether our presenters might have any questions for each other. I guess since Sarah, you've been listening to this, I might start with you and ask, is there anything that you might, any responses you have, or anything you might ask Amy about what she's gone over?
Well, yes. So I found it fascinating to think about what one of our health centers could maybe be a part of in terms of a community conversation, and maybe bringing Prepare or other data to the table to maybe convene a group of people to talk about things that matter to them in their community. And my question for Amy maybe is just do you have recommendations about how a healthcare provider might effectively approach some of the community-based organizations with information that might benefit their work, and how do you think about bringing people together effectively, particularly when healthcare providers can maybe be intimidating to more lay people?
Yeah, that's a great question. Actually, when we first spoke and listening to your presentation, the data that you are collecting, if aggregated and showed in a place-based way, at different levels of geography throughout Iowa, would be absolutely invaluable information. It's so hard to get that from other data sources unless you have a really good, representative survey that asks those kinds of questions of the general population. And so I think that offering data at the level of aggregation that makes the most sense to community-based organizations would be seen as extremely valuable. I would imagine that through home visiting programs or outreach or education initiatives through each of your federally qualified health centers, they probably already have lots of community partners, and I think coming to a coalition of them or coming to them individually to say, well, this is what we've got, how would you like to see it? How could this benefit you? Could start a series of conversations that, could either be conducted as a large community conversation or could be, one-on-one in such a way to try to shape how you could think about some new ways to disseminate and share the rich information that you guys have within your data system.
Yeah, thanks, Amy.
Amy, is there anything about from Sarah's presentation that you might want to touch on? I know that a lot of your presentation also touched on a lot of that as well, but anything else?
Yeah, I mean, I think, Sarah, I'm just wondering, with the wonderful Tableau and data visualization that you guys have, what your plans are for making these data publicly available. Is that something that's down the road from you? Because that would be a great mechanism for thinking about dissemination, you know, geographically with some of these community partners.
Yeah, so the work we've done to build the Tableau environment has actually been with funding from our state innovation model through CMS. And so what we've been working to do is actually not only make our Tableau visualizations available to statewide partners here, but the gentleman who is doing all of our data work is actually documenting a data model, so that if you were using different systems, maybe other than Tableau, you could follow along with the logic and the algorithms that he built to bring that data to visualization. And so I think that tool could be also beneficial to share with others as well.
Great.
All right, so with that, I'll move on to some of the audience questions. I'm going to start out with sort of somewhat basic question. This is from Janie, who asks, what exactly is Prepare? Can any provider contribute or use the assessment? And where is the data stored? Can it be accessed by just anyone?
Yeah, so it's a great question. So Prepare is a tool that was built by the partner organizations that I mentioned during my presentation. It doesn't exist in like a national database or anything like that at this point. So it's really been healthcare providers, primarily federally qualified health centers across the country, that are working with their health information technology vendors to build content to capture that data and then be able to report it out. There is a vision by our national association to, I think, build and house the prepared data at more of a national level, so that it can be used and made available to interested parties beyond the health systems that are housing it currently in their EMRs. I think the suggestion I would have is just there is a team at our National Association of Community Health Centers that will actually field questions and help other interested organizations start to use Prepare or learn more about implementing Prepare. And they do interface with many of the major electronic medical record vendors to build that content. And then I think the other part of the question was around, do we have visions to kind of change the core domains or the questions that we're asking? And I think right now, our National Association has been really focused on working with healthcare providers and organizations that want to implement. And then I think they would go through a structured revisiting of the tool itself, but keeping that tool in alignment as people implement has been really important, so that aggregation can occur down the road. So I hope I answered your question.
All right, great, thank you. A question for Amy. This is from Neil Anjana. Are there any other community level databases for data other than violence?
Oh yeah. It depends where you are. It depends what city or state you're in, and and how good health level data is. Here in Philadelphia, we have what was a biennial, now a triennial phone survey, which asks folks about a lot of health issues, but it's a phone survey. It's not very representative at the neighborhood level. It's representative at the zip code level. So I often will go to other sources to try to find specific data. Violence is for good or for bad, is a health issue where you can get crime incident data, which our Urban Health Collaborative creates small area estimates for, so that we can aggregate it from the tract level to whatever geographic boundary we're looking for. But if you're in a state like where I did a lot of my training in California that has the California Health Information System, and the California Health Survey, which is the largest health survey outside of the National Health Interview Survey, it has a lot more health information that might be representative at the level that you're looking for. So I always start by checking out the landscape. Certainly in a city where I live, I know it pretty well, but to see what's out there and to see what's already integrated, and to see in particular if where you're living has an open data portal. So Open Data Philly has a lot of wonderful data that can be mapped to the neighborhood level that can be used for these kinds of purposes.
All right. Francis has a question for Sarah. Is Prepare adaptable or modular so that it can be used to assess specific populations in a targeted, time-effective way?
So yes, I would say it can be modularized, if that's a word. We don't, the recommendation has been not to necessarily adapt the questions because of what I talked about with aggregating the data, but what we see is healthcare providers across the country that might be asking more granular questions that can roll up into the Prepare response categories. So that's one way that it's been adapted. And then, as more healthcare providers have been interested in implementing this tool, many of them have started with subsets of populations. And so that if I was going to talk about implementation, that would be one of the first things that I would mention, is to really decide, do you want to start with one care team? Do you want to start with a group of patients that might have a common chronic disease, for example? If you're a multi-location organization, would you like to start at one particular geographic location? And so I think that when it comes to implementation, there's lots of flexibility. We've also seen healthcare providers selecting and electing to only ask 3 to 6 questions rather than the entire tool.
All right. And Jamie asks, how can we providers and those who support providers access and implement Prepare and integrate some of these data collection aggregation efforts?
Yeah, so I would point anyone interested in implementing the tool to our National Association of Community Health Centers. They have the most up-to-date accounting of which electronic medical record vendors have really built the content. And so from off the top of my head, I know that there's content built for Epic. There's content built for GE Centricity, their eClinical Works, NextGen. I know they've been working with the vendor Athena, as well as Greenway, EHS Success, those types of products. And I probably don't have all of the products, but being part of the pilot, one of the things that we agreed to do was make the content that we built we were the GE Centricity pilot, and we made that content available so other healthcare providers with a common EMR could use that content. So our national association is the kind of the keeper and houser of all of that.
All right. Jessica asks, what role can non-healthcare professionals play in assessing and screening community members for health risks? And she adds, we are a CBO with no clinical staff aside from mental health therapists, but with strong resource networks and data capabilities.
Mm-hmm. Amy, you might have some comments on this one, but I'll just start with one quick comment. I think any organization could use a tool like Prepare or another, standardized social determinant of health tool. You might be capturing the data in a different type of system where you could aggregate it and look at it, and then bring that forward to healthcare providers or other partners in your community. You might be best positioned actually to really ask the questions. We've talked a lot about empathic inquiry and really treating the assessment like having a conversation with a patient. So that's just a couple of thoughts.
Yeah, and we work a lot with Children's Hospital of Philadelphia and St. Christopher's Hospital for Children here, actually creating fields within EMR for some of the contextual information we're able to provide about neighborhoods that could be linked to a child's record. So for example, pollution or other environmental indicators that could impact asthma prevalence or care coordination. So I think that, just as Sarah mentioned, I think community-based organizations who collect that information and think it could be useful for coordinating care in the clinical setting can certainly bring that to, the local hospital systems or community clinics. But I will say that, assessing social determinants of health within the workflow of providers, is a really important piece of this. But I've seen other models where there are community, peer educators or community health workers or promotoras who are trained to do the assessments with patients or families. All of my research is actually conducted by community residents that I hire and train and human subjects certified to do all data collection. And so if there is a role for your CBO to work with a local clinic and to offer, some social determinants of health screening, whether it's in the waiting room or it's at health fairs or it's at some other place where you have access to constituents because of your trusted role in the community, that's an excellent way to start a new partnership or expand on an existing partnership you may have with that healthcare provider or clinic or health system.
All right, thank you. We have time for one more question. I just want to say we've gotten so many questions and haven't been able to get to all of them, and I'll certainly pass them on to the presenters, and hopefully they'll be able to get back to you. So this last question, I think kind of goes to both of you. The question from John is, what have you learned or do you aspire to learn about how much a place's community health infrastructure, for example, hyperlocal data, locally tailored interventions and partnerships, impact health outcomes? And so I guess let's start with Sarah.
Okay. Well, I think it's a fabulous question. I don't have an answer for it specifically, other than I think to really point at the work that we've done to really try to see more specifically how these social drivers of health impact health outcomes. And so I think it's going to be a whole new evidence base for us, and I do think it will. If we are able to implement it and effectively use the data, we will be able to really, I think through how we organize the resources within the healthcare delivery system in a different way. Federally qualified health centers, when they were first created back within the war on poverty and the civil rights movement, I would say that they were healthcare providers that didn't think within the boundaries of their four walls. And I think that this work can help us get back outside of the four walls of our clinics. But we have a lot to learn. So that would be my response to that. It's a very good question.
Yeah, I agree. That's a wonderful question. And if you couldn't already tell from my presentation, hyperlocal is where I think it's at. I started out evaluating community-based programs and community health worker programs and saw that health outcomes were achieved in those communities that would not be expected from underlying social inequities. And so I like to use a community resilience approach that, let's learn from the communities where things are going better than we would think. It's usually because of the social networks or the community-based programming or the efficacy of community leaders to, address health threats or concerns in their community. Let's not only try to replicate those, but also look at those who are doing poorer than we would think and think about how we could build some of those within the community capacities and infrastructure to be able to see and solve their own problems with support, of course.
All right. Well, thank you for the answer, and thanks so much to Sarah and Amy for these really, really great presentations and discussion about these issues. This webinar will be available online on our MapChats webinars webpage, and we will again send out the video link and presentation slides to all the attendees. Before we go, I wanted to briefly mention how PolicyMap can help when it comes to collecting data on community health, especially social determinants of health. Our recently released community health report gives a complete picture of a community organized by topic like healthcare access, health behaviors, food insecurities, and much more. And if you have a minute or two, if you want to see some of this, I'm just going to go over a little bit of what PolicyMap offers. This is just a screenshot from our community health report. This shows some of the charts that we have related to population, easy to read, and maybe if you want to go beyond just the charts, all of the data that's in the charts is downloadable, and you can always move the charts to another form of a presentation, maybe to a document you're making or to a PowerPoint. We have another section of this report talks about, say, levels of healthcare access, shows from HRSA number of dentists and primary care doctors that are in a community, so you can really address where are there needs that need to be addressed. When you look at a list of what is available in a community, sometimes the numbers really don't tell enough. And so we actually have the data in this report that can tell you, say, if you wanted to look at the nursing facilities, the information, where are they and what do they offer? And that's all available and is downloadable for your own use. And then when you look at charts, this is on rates of health insurance in the area, people without health insurance, who has Medicare, who has private, who has public insurance. If you want to have this data for other uses, it's all downloadable into a spreadsheet so that you can use it for other purposes. And this all comes with what PolicyMap has in terms of easily accessible data and mapping. So you can take social determinants of health data, in this case on median household income, and we're looking at Atlanta, and you can really see how different areas of the city and outside of the city are different in respect to social determinants of health. And you can really look at one area in particular and find out specific details about that area. And then beyond social determinants of health, there's also actual health conditions data, in this case, looking at Lyme disease, which is something that very heavily affects certain areas of the country, but doesn't affect other areas quite as much. And so by looking at the data that's available, you can really see what it is that you need to be focusing on. So if you have any other questions about PolicyMap or any other questions about this presentation, please get in touch. Our email address is info@policymap.com. Our phone number, if you want to get in touch, is 866-923-6277. Again, thanks so much to Sarah and Amy. This is really great. Have a good afternoon, everyone.